Good morning, everyone, and welcome to our next session of the COVID-19 Community of Practice for Ontario Family Physicians. My name is Ali Damji, and I'm a family physician and division head of primary care at Trillium Health Partners in Mississauga. We're really pleased to present today's session on COVID updates and AI to alleviate administrative burden. And the Department of Family and Community Medicine and the Ontario College of Family Physicians are pleased to continue to offer these sessions to our community. I'll turn things over next to the president of the Ontario College of Family Physicians, Dr. Mekalai Kumanan.
Thanks, Ali. Good morning, everyone. It's really nice to have you here with us today. We've got an interesting session lined up for you. As Ali mentioned, we're going to be talking about COVID updates and AI in practice. And just a reminder that this is a Main Pro accredited session. You'll receive details following the session. Next slide. And next slide, please. So moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. Okay, so just wanting to touch on a recent clinic that was opened in my region. I'm actually really excited to share this information. So this clinic was developed in response to local Indigenous needs. It opened in Cambridge in late June, and it's called the Southwest Ontario Aboriginal Health Access Centre, or SOHAC. So this is an Indigenous-led clinic that focuses essentially on providing primary care to Indigenous people in the Waterloo region. And for me, as I reflected on this article and saw the opening happen in my community, it just made me think about the systemic racism that we know that Indigenous people often experience in our healthcare system, and how important it is to have Indigenous-led clinics like this, where we know Indigenous people can both provide and receive culturally safe care. Next slide, please.
Thank you so much, Mekalai. So we're very pleased to have this panel today for you. We'll have Dr. Evans start off with providing our updates on COVID and infectious diseases, and then turn things over to Dr. Crampton to talk about AI scribe technology in keeping with our recent themes around addressing the administrative burdens in family practice and some of the solutions that might be out there with emerging technologies. Next slide, please. So I'm going to turn things over to each panelist individually to introduce themselves. So we'll start first with Dr. Evans.
Hi, thanks very much, Ali. I've been on this before, so many of you may remember me. I'm an infectious disease physician in Kingston at Kingston Health Sciences Center and at Queen's University, and have been very busy with this pandemic over the last 3.5 years. Just to point out, I do have some declarations to make on conflict of interest. I did receive some honoraria from the Ontario College of Family Physicians for the annual conference that was held earlier this year. I've also received some funding from Moderna Australia recently, having gone there to do some talks at conferences and to some of my academic colleagues. And for many of you, you may remember there once existed an Ontario COVID-19 Science Advisory Table, and I was a member of that table before it was disbanded last year. But that's it for me.
Great, thank you so much. Over to you, Dr. Crampton.
Thanks, Ali. I'm Dr. Noah Crampton. I'm a family doctor and researcher at the Toronto Western Family Health Team. In terms of disclosures, I did receive an honorarium for today's webinar, but more importantly is I am leading a startup that is commercializing an AI scribe technology, and the startup's called Mutual Health Solutions, and I'm the CEO. So I'll explain how I'm going to mitigate the bias when I get to my talk.
Great, thank you so much. For myself, my disclosure is I do receive honoraria from the Ontario College of Family Physicians for co-moderating these sessions. Mekalai, would you like to talk about your disclosures?
Yes, sure. Thanks. So my name is Mekalai Kumanan. I'm a family physician in Cambridge, Ontario, and I'm the president of the OCFP, and I'm currently serving as the chief of family medicine at the Cambridge Memorial Hospital. I do receive a stipend for both of those roles, neither of which poses a conflict today.
Great. Thank you so much. Next slide, please. So just as a reminder for our participants, all questions should be asked using the Q&A function at the bottom of your screen. And I recommend taking a look through the questions that are already there. And if someone's already asked the question that you were thinking of asking yourself, please click the thumbs up button, which will upvote that question. Because as the moderator, I'll be asking the questions that typically have the most votes as well. And I can see some of you are already doing that, so that's awesome. For the chat box, please make sure to use that for networking purposes only. So you can use that to talk about the session, your thoughts, what you might be doing in your own practices, etc. But if you have a question, please make sure to put it into the Q&A. It makes it a lot easier on me as the moderator if the questions are all in the Q&A. Next slide, please. All right, so we'll kick things off first with Dr. Evans. So I'm going to turn things over to him. Next slide, please.
All right, thank you very much, Ali. So let's go through some quick data on what's happening with COVID-19. I think it's really important that we're tending not to sort of follow things as aggressively as we used to, which is posing some issues. But let's just kind of look at what the numbers look like as of this lovely, humid July 7th. I want to start off by pointing out to everyone that, we are out of really what is the pandemic phase of the pandemic, but we are now into something called the transition phase. And so what I've done here is sort of point out where we were on January 30th when the WHO described this as a public health emergency of international concern. As everyone knows, by March, they called it a pandemic. So we're not out of the pandemic yet. And this is very typical if you look at the historical context of flu, Spanish flu back in 1918. The last wave of Spanish flu was actually seen in 1928. So really, we're in this transitional phase out of what is the main pandemic phase. And as you can see in this diagram, which is from the WHO, there's actually some little bumps that may occur along the way. And I think that's important to realize as we look at the numbers today. Next slide, please. So this is just a quick picture of what's been happening with the pandemic since way back in the spring of 2020. And what I've shown you here really is just these waves of hospitalization that were associated with various waves. The first two with the ancestral virus, which we now know to be extinct among humans, but very present in white-tailed deer in the province of Ontario. And I'm happy to answer any questions about that. Then we saw the Alpha and Delta waves, and then we've seen all these Omicron waves starting in late 2021 into early 2022. But what you can see here really in Canada in general is a declining numbers despite the emergence of the recombinant XBB subvariants. And that's really the theme for today. Next slide, please. So this is the Ontario numbers. These are laboratory confirmed cases. And what I've done is started it from January of this year. The data goes back much further. So you can see back in January, we had about 7,500 new cases per week. And we had a rate of cases of 50 per 100,000 population. Well, as of the last week, we are now down to roughly about 500 new cases reported a year. Now, some of that is artifactual because we don't test as much, but you can see that the numbers of cases per 100,000 has dropped quite significantly down to about 1/10 of what they were in January. Next slide, please. These are hospital admission counts, and I think everyone recognizes that one of the real challenges we had with COVID and the pandemic was the fact that we were utilizing a lot of the healthcare spaces in managing COVID-19. But you can see here that we've gone from roughly about 550 admissions per week back in January, and we're now down to roughly about 50 admissions per week. And remember that testing, at least in hospitals, continues to be done fairly aggressively. So this is, again, a significant decline from the winter into where we are now at the beginning of summer. Next slide, please. This is laboratory testing, and you can see, of course, here, this is elegantly showing the reduction in the number of tests that we're doing per week from what were almost about 48,000 tests per week back in January. We're now down to about 15,000 tests per week. But what this does show us when we look at the rate of positivity is it's declined from a high of about 16% down to actually just below 6% at 5.9 when reported last week. Next slide, please. This is outbreaks. And again, this is one of the other surrogate markers we can look at to determine community prevalence. And you can see we've gone from over 160 outbreaks per week that were seen back in early January, and we're now down to about 20. And they're broken down, as you can see here, by different settings, whether it's long-term care homes, retirement homes, hospitals, or congregate living. So these are this test positivity, the number of outbreaks are all reduced quite substantially compared to where we were 6 months ago. Next slide, please. This is just test positivity. As I pointed out, we're down at 5.9%, but I track this independently. This is my own little graph from my Excel sheet that I follow, but you can see this general decline. The two lines you see here are really arbitrary, but basically above 15%, we would say we have a high prevalence of the virus in the community. Between 7.5% and about 15%, it's moderate. And then below 7.5%, I consider it to be relatively low community prevalence. I will point out that the province thinks 10% is the sort of cutoff for low prevalence. So I'm a little bit more stringent on that side of things. Next slide, please. The last marker, so this is just, by the way, a trend. I put this out and I've colored it to sort of show where we sort of sit with high, moderate, and low community prevalence. And you can see now here, generally in Ontario, we've now fallen well into the low prevalence territory. So that means the likelihood of acquiring infection out in the community is remarkably low as compared to where it was at the middle of winter and through the most of the spring. Next slide, please. The last thing we can look at is wastewater detection. So we've been doing extensive wastewater detection for a few years now, looking for SARS-CoV-2 RNA, and which has been a useful marker to tell us when there's going to be a rise in cases. But what you can see here is we are at very low levels. In fact, we're probably at unprecedentedly low levels of SARS-CoV-2 present in wastewater across the province of Ontario, and in some places even lower. And you can see that when you look back at 2022, this is actually much lower than, and literally about half of the detection that we saw in the early summer of 2022 when we saw this sort of seasonal type decline. Next slide, please. So really, I use a traffic light system, and I would say the current status of these surrogate markers of outbreak numbers, test positivity, and wastewater detection are all green lights. So they're telling us that we're in a good place at the moment. And this is very typical, of course, of seasonal respiratory viruses, and coronaviruses do exhibit some seasonality to what's going on, plus some of the epidemiologic factors which influence the likelihood of transmission. So we're actually in a very good place at the moment. Next slide, please. So what does this mean, I think, for the use of non-pharmaceutical interventions, particularly as they pertain to offices that you're all working in and clinics, is that masking and the use of PPE can de-escalate to some extent. And as many of you know, certainly here at my hospital and many hospitals across the province, we have de-escalated the pandemic measures and are not requiring universal masking anymore. However, that is contingent on us, of course, continuing to do acute respiratory infection screening. Wearing a mask, if a patient wears a mask, you don't have to ask a patient sometimes if they want you to wear a mask, although that's not an unreasonable thing to do. If they're wearing a mask, you should wear a mask because they're telling you something with nonverbal communication that way. And what we're saying is contact precautions, the use of gown and gloves should still be used, particularly if you're dealing with a symptomatic ARI, or if your point of care risk assessment suggests that you feel that you should use it, or there's an alternative reason to be in gown and gloves for a contact precautions. The thing I'd like to point out, though, is that it is likely as we get into the fall and the respiratory virus season, we're going to see what happens with COVID. It'll likely increase again because it's certainly a novel virus, which is taking advantage of a new population it can infect. And so re-escalation back into more stringent measures, such as universal masking, may be needed on that side. NPI, by the way, somebody popped a question in the chat, is non-pharmaceutical interventions. So you can see here at the bottom, I'll put a little copy of a document that was released by the Ontario College of Family Physicians. Next slide, please. I would encourage you to have a look at it. It's very well done. It divided into 6 sections regarding some of the things that one should consider at one's office or clinic, including screening for acute respiratory infections, masking using point of care risk assessment, PPE use and how it should or shouldn't be used, how you can make sure your office flow is organized such as to reduce risk, and then some of the important measures that one needs to consider, including cleaning with a low-level disinfectant. You don't need to use high-level, but we do recommend a hospital-grade low-level disinfectant. coronaviruses like SARS-CoV-2 can have a fomite transmission. It's not all just due to aerosols or the airborne thing that you often hear on social media. And of course, ventilation is important. And if your HVAC is poor, you should consider getting a HEPA air cleaner to use in either examination rooms or in the clinic in general. So useful document, and I would encourage everyone to have a look at it. I think it's really well done, and it's got some great tips in there. Next slide, please. So very quickly, I want to talk a little bit about bivalent or Omicron targeted vaccines, which, as everyone knows, is now the wave. Next slide, please. So just to point out that in Canada, we still have a relatively low rate of uptake of booster doses. And this is a graph that just kind of shows where it exists in each province in terms of people who have had at least a primary series of 2 or 3 doses. I, by the way, think it's 3 doses, not 2, but and have received a booster dose within the last 6 months. And you can see here in Ontario, we're doing pretty good. We're above the national average at 6.2%. But some provinces are very low. I point out Alberta, which is less than 2% at the moment. So it tells us that boosters are not being picked up as much as we would like them to be. Next slide, please. So as one could imagine, the group that's most likely to have received a booster dose are older fellow citizens, those over the age of 60, and particularly those over 70. But even in that group, you're only looking at about a quarter of them who have received a booster dose. I don't worry too much about children because there aren't a lot of recommendations there at the moment, but certainly in the middle-aged and younger adults, the pickup of booster doses is lower. Next slide, please. So how effective are these bivalent vaccines that include now a BA4, BA5 component? And this is some American data. It's real life data looking at about 1 million people who have had bivalent boosters and comparing them to monovalents. And what you can see here is an incremental improvement in reducing the risk of hospitalization or death. So that can be a measure of vaccine effectiveness. And it's particularly marked, of course, in those over the age of 65. So these booster doses have helped quite a bit. The challenge is that this study was done during a time when the prevalent subvariants that were circulating were BA5 and BQ. Next slide, please. This is another study that looked at bivalent boosters following someone who's had at least 2 monovalent doses or a primary series. And this is broken down by age with young and early middle-aged adults on the left. In the middle are middle-aged to getting to be the older group. And I'm still riling at the fact that age over 65 is old as I approach that age. But what you can see here, and the important thing to look at under the bottom line on the x-axis here is the time since the previous monovalent vaccine dose. And what I sort of draw your attention to is that once you go over about 6 months since your last booster, the incremental benefit is actually much higher, whether you're a young, middle-aged, or older adult. And so that has led to a recommendation that in high-risk populations, those that are over the age of 60, and those who are younger but have underlying comorbidities, that they receive a booster dose about every 6 months, not sooner than that. So that's one of the things that we know, and I won't go into the boring details of somatic hypermutation and affinity maturation that occurs in B cells when they're exposed to an antigen. Next slide, please. This is actually kind of an interesting study, just got published, and it looked at healthcare workers at the Mayo Clinic in the US, and it actually showed that the vaccine effectiveness was very good, as one would imagine, with a BA4-5 bivalent during a dominant phase where the variant circulating was BA4-5. It held true during the BQ dominant phase, which we saw back in the early to mid-winter. But in XBB, which is now the dominant strain, over 95% of all the variants that we're seeing now are XBB, which is a recombinant virus. These vaccines are less effective. This has led, of course, to a recommendation, and it's going to be happening, that the next vaccine is going to be an XBB vaccine, and probably not even bivalent. We really don't need the ancestral part of the bivalent vaccine moving forward. And so that is expected to happen here in Canada, to have those available by September. And I'm happy to answer questions about what that might mean for somebody in your practice who's coming up to the need for a 6-month booster in July or August, because prevalence is so low at the moment. it is not unreasonable to think about them waiting until September when the XBB vaccines become available, because that's really what we expect to dominate over the next year or so. Next slide, please. So this is just a table from the NACI recommendations that were published in March 2023. And I just point out at the bottom, you can see the green lights and yellow lights. So recommendation now is 6-month boosters for people over the age of 65. And if you're between 18 and 64 with an underlying medical illness that either suggests that your immunogenicity from the vaccine would be low, or if you were to get COVID, you would have more severe consequences, those people should be getting boosters every 6 months. Everybody else, the current recommendation, which may or may not change, is to get a booster every 12 months, and no recommendations at the moment for boosters in those under the age of 5 years old. Next slide, please. So just a quick update on what's happening with antiviral therapeutics. As everyone knows, Paxlovid is still available for free for anyone with a prescription, so you can prescribe that, and they can be picked up at community pharmacies and administered. And of course, the challenge with Paxlovid is lots of drug interactions, and many of you may be familiar with having already done this and looked through those to look at what kind of recommendations there are to adjust other concomitant drugs while the patient's on their 5-day course of Paxlovid. Next slide, please. For remdesivir, there is now in place most areas across the province that you can refer those patients, because this is an IV infusion, to home and community support services. All they need is a prescription from you to get that process going. In some places, like where I work here in Kingston, some physicians will actually personally contact the infectious disease docs in my division, for instance, and then we organize it through our clinics here. But this is broadly available to anywhere there's home and community care support services. So I'd encourage you to use that process if you need it. Remdesivir is really being used in a scenario where you can't give Paxlovid and you've got a high-risk patient. So that might be somebody who's a transplant recipient, or it might just be an elderly person where it's just impossible to give Paxlovid because of the drug interactions. Next slide. We don't have the next slide, but anyways, just a reminder about what the doses are. So Paxlovid comes as a pack. It's 3 tablets twice a day for 5 days. 2 of the tablets are nimtrelvir, and the other one is ritonavir, which is a booster. That's the one that causes all the drug interactions. And remdesivir is a 200 milligram IV infusion on the first day and a 100 milligram IV infusion on days 2 and 3. The windows for those are 5 days, ideally within 5 days of onset for Paxlovid, and 7 days for remdesivir. So just keep that in mind as you move forward, and I'm going to be happy to answer any questions that as we move along in the webinar. So that's it for me.
Great. Thank you so much, Gerald. That was excellent and very comprehensive, and I think very much in line with a lot of the questions that we received today. So on that note, we'll jump right in with these questions. So the first one here is about the rapid antigen tests and whether the ones that were available at drugstores in Ontario until last week, do they actually work in detecting these latest variants of COVID, like the XBB?
Yeah, that's a great question. And what's really fascinating is just yesterday, there was a paper published in the Annals of Internal Medicine, which has systematically looked at the reliability of these rapid antigen tests in COVID. Of course, many of you may have seen our Ontario Science Advisory Table brief last year in February of 2022, where we already pointed out that they're very problematic once you get into Omicron. And to be really reliable, you literally have to do them daily for about 3 days, assuming that the first one and the second one are negative. They really just don't have the sensitivity that they had before Omicron. So they are no longer as reliable as they were. And a single rat done on someone who is symptomatic is not reliable enough to exclude COVID by itself. You would have to have them test serially for about 3 days to actually see what the true result would be. So you're still basically relying on a PCR test if you can get them.
That's really helpful to know, because I imagine a lot of us encounter that in our practices, and you know, that counseling, especially around serial testing, I think is really crucial for us to know. So thank you for that. There are some questions, and I'm going to combine a few together that we're asking a little bit about some of the data that you presented, and specifically, you know, how do we know for sure, I guess, these numbers are accurate because we're not testing as much anymore. So I was wondering if you could restate that a little bit more around how do we get these numbers around estimated prevalence when we're not testing as much?
Right. So the thing we're using is not literally anything to do with the, yes, if you're testing less people, you're going to find less cases. And we certainly know that is a scheme that's been used by many, don't have information that could help you. But what we really look at most importantly are test positivity. So we can still look at that, recognizing that it is skewed a little bit if we have a high pretest probability. In other words, we're only testing symptomatic people, not people who are asymptomatic. But COVID RNA testing in wastewater outbreak numbers, which are extensively tested for, are very reliable in telling us that the prevalence of this virus in the community at the moment is very low. It's not gone, and it's almost certain to come back come the fall. But right now, based on the numbers we have, it's very low. And yes, everybody on this call is a smart person who remembers their stats and, all the issues around, testing. Once you drop your numbers of tests, they become less reliable. So we never look at sort of what the data is showing us about cases in the community, because we know we're testing less, so we're going to find less. So what we look at is really a test positivity number. And yes, that can be skewed a little bit. The other ones are not affected by that in any shape, manner, or form. So they're fairly reliable, but they are surrogate markers. They're not absolute markers. Yes, it would be lovely to continue testing at the levels we were doing way back before Omicron. You'll remember after Omicron hit, we just dropped the numbers of people eligible for testing in general. But yeah, it's a bit of a challenge, but I'm pretty convinced when I look at this data, and I've been following it very intensively for about 3.5, almost, pretty well, getting on to 4 years this fall. And I think we can predictably say that there's a lot about what we're seeing in the numbers that fit with the development of a virus that is beginning to become endemic and showing seasonality.
Great, thanks so much for that. I'm going to change gears a little bit and go to some of the IPAC advice that you had provided for us. So someone here is asking about what the harm would be if they just wore full PPE as a universal precaution, because cases will rise again at some point. Any thoughts at all about that type of approach?
Yeah, I mean, you can do that. It's a lot of resources. And as you know, that kind of scenario will affect your office flow. If you're having to gown and glove and masking, you can just keep on your same mask the whole time. You could do that. What I'm just trying to point out is that this is a sort of a period at the moment where some relaxation of those measures may be appropriate. It can help you with office flow. It can help you with, sort of helping your patients to understand and to be able to get in and get access to their opportunities for appointments for other infections or not infectious illnesses of any type. I'm too much of an infectious disease guy. I keep talking about infectious all the time. So I think that's where the advantage lies. There's nothing completely wrong with maintaining a very high standard of PPE. You may help to reduce the likelihood of getting infection, but even the IPAC measures we use, whether it's masking and including N95s or wearing gowns and gloves in your practice, you are not doing that out in the community. So there's always an opportunity for an infection to happen in community if you're looking for sort of a literally almost 100% effectiveness on reducing the likelihood of transmission. And right now we have no public health measures active out in the community, and we're not seeing lots of transmission. So therefore, the presence of the virus in the community and therefore in your patient practice is quite low at the moment. So you're kind of doing something that you don't really need to do, but if you want to do it, there's nothing wrong with doing it if you want.
Thanks so much. And that actually dovetails really nicely with the next question, which is about being out in the community. So at this point, would you say that it's safe to go maskless indoors in crowds in Ontario right now?
Absolutely. I don't want to sound too sort of offstandish, but I just came back from Australia, as I was pointing out. Australia has had that seasonal surge in both influenza and COVID-19. I was at conferences and at university speaking to in large numbers and crowded areas. I didn't get it. That's anecdotal. But their prevalence is much higher right now in their community than it is here. I have no concerns with telling people at the moment, you do not have to wear a mask unless your personal assessment of your risk is high, and it may relate to some underlying condition that you have, maybe perhaps experience with a previous episode of COVID that has you very concerned about the possibility of getting it again. You can do that. It's just so little virus right now circulating in large amounts within the population that would say that going out in public at the moment without a mask is perfectly reasonable to do.
Great. Thanks so much for that, because I know we often sometimes get answers that aren't very clear cut, but I really appreciate that that was a very clear answer. So thank you for that. In terms of the next question here, again on rapid antigen testing. So someone's curious here about what you think about RAT not being available to the public for free from pharmacies after June 30th. Is this good, or will it lead to more spread and less access to Paxlovid?
Yeah, I would say that really in the last year, rats have not had a major contribution to reducing risk. If people were rat testing themselves in the development of symptoms and had a negative, most of the public, except for those that are very well informed, would have just relied on that to say that they don't have COVID when they may have very well had it. So I don't think the reduction in the availability of rats is going to make a huge difference. Obviously, some people who did test themselves and were positive may have then done measures to make sure that, for instance, they weren't circulating in public and therefore at a risk for transmitting it to others. But I really want to point out something that, I don't get a chance to talk about a lot. There's a fair bit of data that if you have been vaccinated and with a primary series of at least 3 shots, there's 2 things that happen when you get COVID. And remember that vaccination rates are above 85% for people with a primary series. So if you've been vaccinated and you get COVID, the amount of virus that you shed is much less than somebody who is unvaccinated. And secondly, the virus that you're actually shedding is less infectious. So this is really one of the key things, that the most important thing that you can do, anyone can do, to prevent transmission of COVID is to get vaccinated, not necessarily to test yourself and then, if it's positive, sort of reduce your exposure out there. So again, we've moved through phases in the pandemic, and when rats first became available and they were reliable during the ancestral Alpha and Delta periods, they were useful, especially with large numbers, to keep people out of circulation and reduce that transmission risk. Once vaccine came along, vaccine actually is the much more important method and procedure that we use that actually helps to reduce transmission.
Again, thanks so much for that, because I think that, again, this really helps us when we think about our counseling for our patients and trying to educate the public about what measures they can take to help us address transmission and reduce that risk. And I think that's a really important piece that we don't often think about. So thanks so much for that. In terms of another question here, so this one kind of touches a bit on some of the inequities that we saw during the pandemic, with different regions experiencing COVID differently. For myself, I work in Peel, and so certainly we saw a significant impact of the virus. And this particular physician is from Scarborough and is asking if there are pockets of heightened COVID-19 activity. Is that being seen at all, where certain communities are still experiencing high levels, or does the data seem to suggest that overall the prevalence is low?
Well, certainly when you look at Ontario regions, there can be a big difference. I showed you the general overall Ontario numbers of test positivity at 5.9%. Where I am here in southeastern Ontario, test positivity is 1%. So yes, there is some variation. As to neighborhoods, particularly in high density populations like the GTA, we certainly continue to track neighborhood rates. However, testing numbers are way down. And one of the things that we saw even early in the pandemic is that testing is variable amongst the population. In other words, people going for PCR testing, which gets into our lab information system, which we can then map out with administrative databases to look at neighborhood disposition. So that's become a little less reliable, simply because almost certainly right now in some of the neighborhoods that are what we'd call socioeconomically deprived, the testing numbers are very, very low as compared with other neighborhoods. So then it becomes unreliable, because you're not testing that many people to determine if there's a very high level of test positivity in those areas. It was certainly a feature of the early part of the pandemic, and it is one of the things that the Science Advisory Table used to direct and try and inform government about policies to ensure that, for instance, testing was available in areas where there were high levels of COVID, and as well during the vaccine rollout, because we recognized that neighborhood deprivation was an important factor, along with age, that predicted the likelihood of severe COVID. So I would say now the data that we're still collecting on that is a little less reliable than it was, but we certainly know when we look at the large regions of the province, as I stated, there could be a huge difference. Most of that 5.9% I showed you for test positivity would tend to predict the high population areas of Toronto, Hamilton, and Ottawa.
Great. Thanks so much for that. So this question, I think, is a clarifying question to what you had said before about the COVID boosters and the recommendations around the intervals. So for seniors who, let's say, had their last booster in October, if they haven't had a booster since or COVID, would you recommend that those individuals get the booster now because it's been 6 months, or should they wait until the fall for the new one?
Yeah, that's a great question. It's actually the number one question I've been getting recently. I've had a lot of my physician colleagues reach out to me with exactly that kind of scenario, or more commonly a scenario where somebody got a booster in January, they're now due for July. And with recognizing that XBB now really takes over the entire landscape, with low prevalence of the virus, if that person's continuing to be very careful about reducing their transmission through non-pharmaceutical interventions, I would say it might be reasonable. You could suggest to them to wait until September when the XBB vaccines are going to become available. If, however, you've got somebody who's very high risk, probably not necessarily wanting to be particularly careful when they're out in public or whatever, despite that low prevalence, there's always a risk. And if they haven't had a booster since October, yeah, I'd probably be pushing it potentially for them to get one now. But if you do it now, at least it allows them the possibility of getting their next booster, which will be an XBB variant, by December, when we're into the respiratory virus season, right? So you can always take it by the tact of having the vaccine as close as you can to the period when prevalence in the community is high is probably a better strategy than worrying about getting a booster now when prevalence is really on the very low side. And remember that within the first 2 to 3 months after you've had a booster shot, there's actually a reduction in the likelihood of being infected, period. Not just a reduction in severity of disease and the risk of hospitalization and death. That wears off after about 2 or 3 months. And then you're just back to enjoying the benefit of the protective immunity you get from the vaccine. But within that early period. So, I think you're going to see people coming in saying, well, it's October, November, and I'd like to get my booster shot now because this is when we're heading in respiratory virus season. Kind of like what we do with flu shots, right? We give flu shots just at the beginning of the season because we want to take advantage of the fact that it's more likely someone's going to get the infection during the next few months.
Mm-hmm. Yeah, that's so true. And I think a common thing I hear about is wondering if eventually a company might create a combination flu and COVID vaccine, right? And kind of get both of them done at once.
Yeah, they're coming. I would say that we're probably still a year away from having those. They are in trials at the moment, and of course the technological side of things is really what they're working on. But I don't think we'll have those available in the fall. I haven't seen any sign that they're likely to get through registration at the moment. So we're really just looking at an XBB COVID shot, and we're still looking at the regular flu shot that you would get typically in October or November.
So thank you. Before we turn things over to our next speaker, I wanted to ask one last question. I think it's timely, especially since it's the summer and beautiful weather. So it's about travel. And I know you mentioned that you recently had traveled yourself as well. And there's a few questions here about, how to best optimize safety during travel. Is it still recommended that someone wears an N95 mask on a plane, which I can imagine would be quite uncomfortable for a flight all the way to Australia? Or are there other recommendations that you might suggest if one is thinking about traveling or if our patients are thinking about traveling?
Yeah, this is a topic that I'm very familiar with, not just because I recently traveled, but because I've been asked about this so much. I even presented a talk on this. So let me point out that the ventilation in modern aircraft is such that you really don't have to wear the mask when you're on the plane. The airflow is from up to down. And it's HEPA filtered. So you really don't need to have a mask. I suppose if the guy or the person next to you is coughing and sputtering and looks like they're febrile, yeah, I'd probably put a mask on. But that would be, I would say that's one of those mom-like recommendations more than anything to do with COVID. The risk during travel, particularly air travel, is actually as you're waiting to board the plane in the waiting room area, sort of the gate area where you're going to be, because that's where people are crowded. Everyone who's traveled recently knows it's still like that. And during the early period when the plane has not actually got its engines up and running and everyone's getting into their seats, those are sort of the two main risk periods where it's likely that, if you were exposed to something and were susceptible, that you would likely get an infection. While you're traveling, though, you probably don't need a mask. And then, the other aspect to think about is where you're going. So I was just in the Southern Hemisphere. Well, the Southern Hemisphere, it's winter right now, and that's why their COVID activity is higher. And so if you're traveling to the Southern Hemisphere at the moment, you're basically traveling into influenza and their COVID season. So in that scenario, maybe your practice would be to think about wearing a mask or using other kinds of interventions to avoid crowded circumstances in order to reduce your risk of infection while you're in that particular destination.
Great, thanks so much for that. So I'm gonna actually just squeeze in a couple more questions because I know there's a few here that seem pretty timely. So one here is about the rapid antigen testing, and if you have a recommendation on what days are best to test, like in terms of the days of symptoms, is there a recommendation regarding that?
Yeah, so the current recommendation, if you're going to use rats, serial testing, start on the first day of symptoms and do it for at least 3 days, the first 3 days of symptoms. That seems to have the best opportunity of actually finding a true positive. Otherwise, you're really dealing with a lot of false negatives. Testing beyond 3 days has not really been well looked at. In other words, would you be better at day 5? It doesn't make sense with what we know about viral shedding, and the most intense days of viral shedding are usually about 24 hours before the onset of symptoms, and for those first 3 days. At that point, viral shedding reduces. So if you're thinking about how the rapid antigen tests work, it's probably not useful at that point. So start on the day of symptoms, at least daily test for the first 3 days.
Okay, perfect. Thanks so much. So with that, we'll turn things over to our next speaker. But Gerald, as you can see, there's still quite a few questions in the Q&A box. So for those who ask questions, Dr. Evans will try to answer those for you as well too. And we can always come back if we have some extra time at the end. But with that, I'm delighted to turn things over to Dr. Noah Crampton, who's going to be presenting about the future and AI. So over to you, Noah.
Thanks so much. So why don't we just jump right in? So I'm a family doctor at Toronto Western, and I've come to this subject matter over the last few years, and I'm excited to talk to you about what AI scribes are. So next slide. So I do have a conflict I mentioned earlier. I am the CEO of a company that is commercializing an AI scribe technology here in Canada, and the company is Mutual Health Solutions, and the product's called AutoScribe. Next slide. So the way I'm going to mitigate the bias is by showing my product alongside 3 other competing products, with giving equal time and amount of coverage to both. And the OCFP has reviewed these slides and has approved them. All right, so we're going to review common pain points that AI is trying to solve and the existing use cases in family medicine. We're going to spotlight AI scribes. What are they? How do they work? And we're going to go through some FAQs on AI scribes. Next slide. All right, so our current healthcare system. I know it's a bit of a busy slide, but we all feel like we're coming out of the pandemic. It was like we went to war together. But at the same time, we've had these EMRs that helped in some respects with our workflow, but also added a lot of admin burden was downloaded onto us. At the same time, we haven't been remunerated more for this extra admin effort that we've been experiencing over the last few years. So AI is here. Is it going to help and alleviate the burden? It's early days, and hopefully that's the case. Next slide. So like the way I view this is that AI is a transformative technology along the lines of electricity and the internet, and it really is a possible savior from us in terms of the admin burden crisis that we're experiencing, and hopefully will help to turbocharge the quadruple aim in a way that aligns with our values. We just have to make sure that we're leading this, that that commercial AI is not happening to us, but rather we're at the forefront of it and embedding our values and making sure it's designed with the relevant policies and regulation. Next slide. So AI was touched on at a previous community of practice in general, the new large language models underpinning ChatGPT, et cetera. But just at a high level, artificial intelligence is that theory of and development of computer systems that can perform tasks that normally require human intelligence. Machine learning is the subset that really is executing on this with in the day-to-day use of AI that we experience. With deep learning being a subset where there's a lot of neural networks going on, that's hard for us humans to actually understand how they come to their results. But with the statistics that's powering them, it's amazing in that they are able to do so. Next slide. So this is a nice summary picture of how artificial intelligence will transform primary care. There's clinical decision making, diagnostics, advice and triage, risk prediction, intervention, digital health coaching, paneling and resourcing, chart review and documentation, practice management, device integration, population health management. So there's a flurry of activity in all of these domains, and they all impact us in our workflow. Next slide. And I just highlight some existing research articles that are under each of these sections of where AI already has activity. Where I really am passionate about, again, coming back to the administrative burden, is really about chart review and documentation. So that's my area of interest. Next slide. So charting and documentation obviously involves language. So we have to think specifically about how AI applies to language to actually work. Next slide. And really that's at the interface of computer science and linguistics, and the area of that it's called is natural language processing, or NLP for short. Next slide. So AI-based scribes and EMR assistants use NLP to listen they use the speech recognition to listen to the audio of a doctor-patient conversation, and they use the NLP to process that conversation into a medical note. So essentially, AI scribes are not dictation tools. Dictation would be directly whatever is exactly being said word for word, versus AI scribes convert the conversation into the prediction of what the medical note would be. And in clinics where human scribes are used, so basically if you had a human in the room with you doing the charting and the entries into the EMR, there is significant benefits in terms of reducing the administrative burden, but obviously it's at a much lower cost when you do it with an AI scribe compared to the labor of a human scribe, without that turnover that occurs when you have to, if a human scribe, you hire one and then they leave, you have to hire and train again. That is obviously doesn't occur with AI scribes. Next slide. Okay, so just at a high level, we know that doctors are burning out, and studies show that a lot of that is due to the administrative burden that we're experiencing, such as charting. And studies show that we're actually spending nearly 50% of our time on this desk work, rather than what we actually went into medical school for, which was that human connection with patients, being the healer, connecting and providing our clinical judgment. So we're trying to rebalance our work time to the latter. Next time. So how does AI scribes get us there? Well, it helps to automate charting in a nutshell. As you can see in the picture, there's the doctors focusing on the patient without having to focus on the computer anymore. So the clinician-patient conversation is transcribed with the microphone attached to the exam room computer, or it could be your smartphone. In real time, the AI is generating the medical note for that doctor. And so at the end of the visit, there'll be a final AI note, and the clinician is tasked with reviewing that note and editing it. Which with the editing effort is much less effort than writing or dictating the note from scratch. And what's important is that we track those edits so that, if the AI was off, over time, the AI will learn from those edits and become more accurate. Next slide. So there are proven benefits already coming to that. So obviously more engaged doctor-patient experiences. Importantly, more efficient, cost-effective clinical encounters, so you're not writing your notes during the visit or late at night, and the administrative burden is alleviated to focus on other higher value clinical activities. Next slide. So I'm just going to go through a few examples that exist right now in terms of companies and technologies. So many of you are familiar with Nuance in terms of the Dragon dictations tool. So they now have a new scribe technology called Dragon Ambient Experience, called DAX. Currently, they are not available in Canada. Next slide. This is my technology, AutoScribe, part of Mutual Health Solutions. And so we are available in Canada. Next slide. Tally AI is also a scribe technology available here in Canada. They're part of the Well Health network. Next slide. Suki is another technology where they have EHR navigation and through voice direction, and also a scribe technology, mostly smartphone based rather than computer based. They are not available in Canada currently. Next slide. Deep Scribe is another technology. They have sort of a implementation with a human in the loops, and they have these sort of metrics in terms of how their performance is. They are not available in Canada currently. Next slide. So with the new power of generative AI, you may have heard that term, or large language models. This is what is powering the ChatGPT revolution. It's able to listen to an entire conversation and keep track of the context of what's being said the entire time. It's really amazing. So the outputs end up being very accurate when you actually measure them. And what it does is what the technology is doing is it's basically predicting what the next word or phrase would be based on the input it has. So you have to work with what's called prompts, prompting to make sure that you're getting the output that's desired. And prompts is actually just written in language, but in a way that is optimized for the AI to understand. And there's the next study that I'm showing here, AFP Innovation Lab, reducing documentation through the use of digital assistants. This is showing practically the benefits of what we're seeing with AI Scribe. So next slide. This is going to be with the Suki product. So as you can see, before they were using the AI Scribe, they were in the 10 to 18 minutes depending on the provider of time with the patient. And look at how dramatically reduced, 50-60% of time less spent, and also after hours as well. Next slide. And then there's reported, self-report in terms of provider satisfaction. No completion is improved. EHR tasks are less burdensome. All these factors have improved significantly in this study. Next slide. Okay, so now we're going to get into the FAQ part. Technology. So what's the technology required? Well, as I mentioned, you need the computer or smartphone or tablet that is approved by your organization for use with patients. And that's usually the computer with the EMR in the exam room. You need a microphone attached to that computer. Generally, the desktop built-in ones aren't good enough. So you need like a external conferencing one attached through the USB port. And obviously a reliable internet connection with adequate upload-download speeds. And so, for those who are in Ontario where internet reliability may be an issue, it might be of interest to run tests with your preferred AI Scribe vendor before trialing it. Next slide. So here's a big one, obviously, legal, privacy, and security. This should be top of mind before you trial this out. So any software application that stores personal health information must undergo rigorous privacy and cybersecurity assessments. I'm sure many of you are already familiar with the FIPA legislation. The rest of Canada will adhere to PIPEDA or HIPAA in the US. And the way you would demonstrate that is by doing third-party assessments. These should be done by reputable companies in terms of threat risk assessments or TRAs, penetration testing, privacy impact assessments or PIAs, and proof of cybersecurity insurance. So practically speaking, what ends up happening is like the large healthcare organizations tend to have that internal staff to do those reviews before procurement and whether it meets their internal requirements. If you're a community doctor or clinical manager without access to those internal experts, I'd recommend that you speak with Ontario MD. They are like our voice for digital health in the province, and they would have a lot of feedback for you on whether you're doing an adequate enough assessment, and your business's lawyer to ensure that this is a third-party ancillary software to your EMR. Is it covering the essentials of privacy and security? Next slide. Patient consent is another big one. Having a conversation audio recorded can be a jarring new proposition to patients. So confidentiality is really important. So it's unclear to the patient, though, how that data, the audio recording data, is being used, and that can have a chilling effect on how what information the patient share with you. So it's really important that you get informed consent from a patient before using an AI scribe, explaining why you're using it, its benefit and risks, and it's very explicitly how the vendor legally commits to how they're using that data. And so speak to your chosen vendor if they've developed any pre-developed consent tools and change management processes, which ensures the completeness and efficiency of obtaining consent. Next slide. So regulation. First and foremost, it is encouraged to directly speak yourself with your legal body and professional representatives about, such as the CMP and CPSO about this. Because this is early days, right? So in general, these organizations recognize AI scribing as a new technological tool. But it's so new that it has its own inherent risks. But if an AI scribe vendor is meeting the robust privacy and security requirements and patient consent, these bodies are not committing to a stand for or against at this point. They're still doing their due diligence about how to proceed. Health Canada also only classifies diagnostic and therapeutic prediction software using AI as a medical device. So for instance, they don't consider Dragon as a software as a medical device. So Health Canada is not regulating AI scribe software at this time. Again, that landscape may change. Next slide. So what are some features to look out for when you're deciding between different AI scribe vendors? Obviously, the accuracy of the AI is important. The speed, is it a real time or is it just the output at the end of the visit? Can the AI output to your preferred templates and writing styles? Which EMR is it integrated? Is it good for all medical specialties? Is it adhering to required documentation standards? Sometimes they can map to structured clinical codes. Is there any value for patients? Does it generate summary handouts for the patients? And really importantly, and I'll stress this one, is the trust and transparency of the vendor using that data appropriately. Is there a governance in place about how that data is being used? So speak to other doctors who are already using AI scribes, maybe the early adopters in your network. Languages and accents is a really important one. It's only as good as the speech recognition technology that's currently available. English, obviously, in the North American accent performs the best. So I would say, you have to acknowledge currently that where this technology stands is that there may be a higher error rate with AI scribe accuracy with patients in other languages or accent, which is really an inherent equity issue. So speak to your AI scribe vendor, how are they addressing this equity issue in the long term? Next slide. The AI bias and hallucinations, the data sets that the AI is trained in can have inherent biases. So you really want to think about what your AI scribe vendor, how they're addressing the bias that can be part of the data that's powering their AI. And that's something that can only be addressed in the long term with new data that flows into the system and how it's added in. Hallucinations is basically these new large language models in their generation of an AI output can spontaneously predict something that's completely inaccurate and unrelated to what it was prompted to do. So that's, if prompt engineering is done well, it can be really minimized, but sometimes it can't be brought to zero. So it's really important that you review the output before approving it. There tends to be like once technology gets really good, we tend to rely on it without doing our thorough review process. But hallucinations can pop up, 1%, 2%, 3% of the time. So we really have to make sure we don't miss those. So challenge your AI scribe vendor on those 2 points. How are they addressing bias and hallucinations? Next slide. So prices, this is a new area. Prices obviously depends on how the AI scribe vendor is actually built in their technology. And so it's all over the map, anywhere from $50 to $1,600 per month is what I've seen. So really just do your due diligence on what are the vendors' features that are providing you, how do they adhere to the policy requirements, and is it in alignment with your values as a doctor? Next slide. All right, I know that took a little bit of time, but I wanted to get as much information up front. You can email me at noah.crampton@mail.utoronto.ca. Thanks so much.
Perfect. Thanks so much, Noah. So we do have some time for a few questions. Now, I will note your presentation was so comprehensive. I think you answered almost all of them. So some of them I might just kind of restate what you had already said. So one was a question related to does AutoScribe or other AI technology work with other languages and accents? And I believe you had answered that that's sometimes where the gaps are, and so you need to talk to your AI scribe vendor about that. Would that be fair to say?
Yeah, exactly. So this is a work in progress, and it is one of the areas where depending on which technology is being used under the hood, an AI scribes vendor technology might be more performant than others. So really, if you have the bandwidth to do a due diligence on evaluating that, that's great. And then also, what is the commitment of the AI scribe vendor to improve that over time?
Mm-hmm. And there has been some commentary in the chat as well too, which I wanted to draw everyone's attention to. So there were some questions about this technology sounds amazing. It sounds like it can really enhance someone's practice, but the big challenge is funding. And as family physicians, we're covering these costs ourselves in an era where there's inflation and so many other challenges to be operating a practice in the first place. And so the question came up around is there opportunities for this to be funded by the government? And we're fortunate that we have someone from Ontario MD present on today's session, and they just mentioned that it is something that's an area of advocacy. It is something that's going to be flagged and brought forward to the ministry. So hopefully there will be opportunities for this technology to be funded. So we'll need to stay tuned, but I just wanted to flag that it is something that's being actively worked on. And I don't know, Noah, if you have any comments on that since you work in this space.
Yeah, it's there's a flurry of activity, and I'm doing my own part in that advocacy, obviously, both from a physician as well as which scribe technologies end up being supported by the government, because my whole thing is EMRs happen to us. We did not lead how EMRs got implemented, and we ended up having some challenges with that later on. So let's be at the initiative of this AI revolution. Let's be at the forefront of it. Let's make sure we design and value according to how we as family doctors really want it to work for us.
Awesome. And you're getting a lot of support from Chandi from Ontario MD as well for those comments. So thanks for that. In terms of some other questions here, so a big one that comes up is privacy, and I know you did touch on that as well, but maybe just to kind of clarify that a little bit more for people, I think the big question is that if AI is learning from successive encounters, are there any privacy risks with that, with the fact that it's sort of using, the first patient encounter to then learn for the second one? Like, are there issues with that, or can you help clarify that for us?
Yeah, so right. This is like the big difference between traditional software and AI-based software, right? AI-based software there's a continuous data stream that continually improves the actual software, right? It's not like you design it, it's set in stone, you release into the wild, and that's it, right? So that's exactly how on that point exactly is why we have to think about how are we going to be, as a profession, as a part of a health system that generates enormous amounts of linked data on our patients. What are we going to think about how that data flows into training those AI models, where most of them, frankly, will be done by commercial entities with, not public interest motives necessarily as us doctors, right? I'm leading a startup myself, so there's a bit of a commercial motive there too. So how do we design that so that, there's a mutually beneficial arrangement where that data flows in, it's done in a secure way where no other human is seeing that data. It's just the AI is continuously retraining and improving from it. I think that is the big question of how this is going to unfold, because what I'm worried about is it's going to be some big tech company. It's going to hoover up all this data. Tons of humans are going to look at the data without proper consent procedures in place. That's not where we want to go.
Yeah, definitely, definitely. And I think it's really clear that you're saying really this needs to be led, by physicians who understand this and understand the implications of that as well. And we're grateful there's people like you that are leading that charge for sure. So that's wonderful. In terms of the recordings themselves, like when the AI actually, or maybe not a recording, but when it's listening to the encounter, is that stored anywhere and is that able to be accessed at a future time? Let's say, for medical legal purposes, or, if there were, a need for you to go back into the actual source recording, is there a way to do that with this technology?
So certainly, and again, like this is where how AI scribe vendors are preparing for the ultimate regulation that comes down for this is like a key differentiating between vendors, because I can speak for myself how I've been very much thinking about how that is going to have to play out, because there are certain vendors where you store the audio and it's there forever, and yeah, you have to think of it medical legally. For instance, is that audio file more accurate compared to the note that we put in our EMR? And then let's say that was subpoenaed and it went to trial, but there was a discrepancy between those two. Like, think of that possibility. It's very, very weird and strange to be in that scenario. And we want to make sure that we avoid that. We want to make sure that the doctor is the one that is the ultimate clinical reasoner here and is putting down on paper how they've distilled what's going to happen with that patient in that visit. So for now, that medical note should be the true source of truth, right? Versus what we're doing at my company, and again, I'm not trying to market my company at all, but we're following guidelines about what's called data in transit. So we're keeping the audio only for the necessary amount of time that's needed to ensure quality assurance that there wasn't a catastrophic technical failure. And we've deemed that 28 days, which is in alignment with other ways that data in transit in the health system is perceived. But other companies don't do that. So just to see give an example of that difference.
Perfect. Well, thanks so much, Noah. I see we're at time for today's session, so I'm going to close things off there. But of course, I saw that you had left your email, and we'll certainly, if you're okay with that, we'll circulate that. And I know there was a request for it to be dropped into the chat if you're okay doing that. And people can feel free to reach out to Dr. Crampton with their questions about this technology. And with that, I want to thank everyone today for coming to the session. I know it's the summer and it's a busy time, and I really appreciate everyone spending their morning with us today. Our next community of practice will be on July 28th. So please stay tuned for that one. You'll get a message in your email along with the survey, which allows us to get feedback on today's sessions and improve them for the future. Lastly, you will also receive the webinar recording and the Q&A and copies of any resources that were shared today as well. And that'll be in that email too. And so with that, I wish you all the best. Enjoy this wonderful, humid and hot weather. And I look forward to seeing you all at the next session. Take care.